oxygen for MI and COPD, and one of the things that I ran across when I was looking at this topic. So for MI, everybody thinks that we ought to, a lot of people believe that patients that you think are having myocardial ischemia ought to be getting supplemental oxygen. So there have been a number of studies that have come out recently, Dr. Torrey mentioned. And the question is, in patients with MI who are not hypoxic, that is, the pulse ox is greater than 90%, the supplemental oxygen compared to room air lessen adverse outcomes, which include mortality, reduced quality of life, recurrent infarction, arrhythmias, and infarct cells. So, since 1900, supplemental oxygen has been given to MI patients. I wasn't practicing in 1900, but there were others who may remember folks that were. And in a 2010 survey of British health workers, 98% of them use supplemental oxygen, so it's pretty common. And I think in the emergency department where I work, I think it is not uncommon for patients to be put on oxygen if they think they're having myocardial ischemia. So it's known that there have been studies in healthy volunteers that show that supplemental oxygen increased cardiac output by 10% and increased myocardial perfusion by 22%, and oxygen may also increase coronary vascular resistance. And a 2015 study showed some adverse effects of oxygen, so I just want to go through the evidence in the literature about this particular question. So this table is a table of the studies that I found in looking through the literature, and the table has the first author and the year. So it started in 1976, going down to Hoffman in 2017, and where the countries that were done. So two in the UK, one in Russia, one in New Zealand, two in Australia, one in Sweden. And you can see that the number of patients that are involved in these studies, and these are all randomized controlled trials, the number of patients in all the studies except Hoffman was 1559, and the Hoffman study alone had 6629, so it had like 4 times the number of patients in that particular study. And the Stubbs study was the one that called into question whether supplemental oxygen was good or not. So the list of the studies is here, and you can see that we're go backwards. Yes. Okay, well, there we go. All right, so the zeros indicate that there is no change in mortality. And the other comments, you can see that some of the different studies looked at different outcomes, mortality, recurrent MI, arrhythmia, and infarct size. So the Stubbs, the Dion study had shown that recurrent MI, that supplemental oxygen was worse, and arrhythmias was borderline worse. It was just the p-value was 0.05, so it was just barely statistically significant. But the Stubbs study was the one that sort of started this out, people paying attention to it, and showed that for 3 outcomes that supplemental oxygen was worse, but the Hoffman study showed that there was no difference. So the Hoffman study is the most recent study. So, and there have been 2 meta-analyses. Hoffman was in neither of them because they had been done before Hoffman was published. And they showed that recurrent MI, one meta-analysis showed that it made no difference, and the other one showed that supplemental oxygen was worse. Okay, so supplemental oxygen is probably not helpful, so there's no study showed that it improves things, and there are a few studies that show that it may be harmful. So obviously we're awaiting organizational guidelines from different medical societies and specialty societies to give us advice as to whether we should follow what shows up in the literature. Okay. So the next question was, that I was requested to address, was COPD. So in patients with exacerbation of COPD, the supplemental oxygen compared to room air cause adverse outcomes. So when I was going to medical school, we were taught that when COPD patients are retaining CO2, drive is dependent upon oxygen in the blood, and that if you give them supplemental oxygen, they'll lose their respiratory drive and stop breathing and die. So that's probably not a good thing. At least I don't think so. So it sounds ominous, but is it true? So supplemental oxygen by nasal. There are two questions that I addressed. One was the supplemental oxygen by nasal cannula harm COPD patients, and the second was about non-invasive positive pressure ventilation and IPPV, like CPAP or BiPAP. So I could not find any ED studies comparing supplemental oxygen to room air in COPD patients. So nobody has done a study, as far as I know, in the emergency department, looking at whether adding oxygen by nasal cannula harms COPD patients. However, there are studies on COPD patients at the end of life, and results with these patients may be extrapolated to ED patients, and basically no harm was found when they were given supplemental oxygen, and there was some limited evidence that supplemental oxygen made these patients feel better. So whether or not these were end-of-life patients, so most of them were going to die anyway, but at least the supplemental oxygen seems to bring them some relief. Extraminal in 2016 had a paper called Oxygen for Breathlessness in Patients with COPD who do not qualify for home oxygen therapy, and they found that supplemental oxygen reduced breathlessness during daily activities or exercise. It had no effect on reported quality of life, and the evidence was low quality, but it was a study that was reported. Ergen had not. You hear? So Ergen and Nava in 2017 had a study titled Long-Term Oxygen Therapy in COPD Patients Who Do Not Meet the Actual Recommendations. It was a systematic review. There was an adequate search. It was well done. There was an adequate search study. However, there was no assessment of study quality and no meta-analysis was done to combine the data. They found that COPD with patients with moderate hypoxemia, with a pulse ox of 89 to 93%, a PO2 of 56 to 65 millimeters of mercury, and a PaCO2 of greater than 45 millimeters of mercury in that study. They found in that meta-analysis, they found 3 studies that compared supplemental oxygen to room air, a total of 919 patients that were followed for 1 to 6 years. And the overall result was there's no difference in mortality and time to hospitalization. One study showed that supplemental oxygen stopped the decline in endurance time and reduced exertional dyspnea. So all the studies that we found so far that I can identify for COPD do not show any decreased benefit, any harm of supplemental oxygen for COPD patients. Now, Orandek in Conference 2017 looked at the non-invasive ventilation. So now we're talking about NIPPV or like CPAP or BiPAP. And they found that the review was entitled Non-Invasive Ventilation for the Management of Acute Hypercapnic Respiratory Failure due to exacerbation of COPD, and they define acute hypercapnic respiratory failure as a pH less than 7.35 or a PaCO2 at greater than 45. And what they found that the benefits of NIPPV versus a standard treatment was that the mortality, there were 12 randomized controlled trials, and the number needed to treat was 12. The need for intubation, there were 17 randomized trials, and the number needed to treat was 5. And so what that means is, for example, for the number needed to treat, it means that if you treat one patient with NIPPV versus not treating, then if you treat, 5 patients with NIPPV, then you would save 1 life, which is a pretty strong treatment effect. And hospital length of stay also was, there were 10 studies on that, and there were 3 less days of hospital stay in patients treated with NIPPV versus not being treated with NIPPV. So that's pretty strong evidence that NIPPV is, so CPAP or BiPAP is really pretty beneficial to COPD patients. So obviously if supplemental oxygen was harming them, they probably wouldn't have found that result. There are other results in that meta-analysis. There were no significant difference in the length of ICU stays, and increased complications, and 6 studies showed increased treatment tolerance, which means that people that are familiar with CPAP or BiPAP know that the patient has a mask on, and there were a considerable number of patients that could not tolerate the mask. Okay. So, in conclusion, for this part of the talk, supplemental oxygen is probably not harmful to COPD patients, and NAPPB is helpful. So as I was looking through this, I ran across a paper that addressed critical care patients. So we probably think that if you have a critical care patient who is not on vaccine, it could probably be a good idea to put them on supplemental oxygen. So I'm just going to spend a couple of minutes looking at the evidence for that. Okay, so Chu et al. Had a meta-analysis. It was a well-done search strategy, so it was a good meta-analysis. It had 25 randomized controlled trials in it, a total of over 16,000 patients. And they found that, so this was a peculiar meta-analysis, because what they did is they looked at studies on critically ill patients, and they compared where the authors of the studies had compared giving high FiO2, high oxygen, versus slow oxygen. Okay, so there were a number of, obviously, different studies had different ways of giving the oxygen. Nonetheless, these were randomized controlled trials again that looked at critical care patients. So liberal oxygen supplementation had an FiO2 of between 28 and 100%, and conservative had between 21 and 50%, and the outcomes were mortality, hospital discharge of 30 days, and morbidity, disability, acquired infection, length of stay. So this is probably something that might be unexpected. You might think that critically ill patients would benefit from supplemental oxygen. So what they found is that liberal oxygen, giving lots of oxygen to these patients, was worse than giving little oxygen to these patients. So the number needed to harm was 71, which means that in terms of mortality, that if you treated 71 patients with low oxygen versus high oxygen, you would save 1 life. So if the outcome were an infection or something else that can be otherwise treated, you might think that a number needed to treat of 71 was not very good, but we're talking about people dying, so I think that this is of considerable importance. And furthermore, as I'll show in a minute, the effect increases when